We'll see. So I'm here to talk about the mental health rehabilitation services in the District of Columbia. Just to give a brief history of this services for people that are struggling with mental illness. DC government throughout its history had a department called the Department of Behavioral Health, and they were the primary body in providing mental health rehabilitation services to people that had been diagnosed with a mental illness in the District of Columbia. Most of their work or their interventions with people with mental illness was in the form of hospitalizing people at St. Elizabeth's Hospital. What that led to is many people being left in the hospitals for years, which led to the concern about we're just institutionalizing people with mental illness. And by keeping people long-term in hospitals and institutionalizing them, that many people were not getting better. They were actually getting sicker with their mental health illnesses because they started to get used to being hospitalized. So there was a decision by the Department of Behavioral Health about helping people return to the community and provide community-based support, provide services in the community so that we can move people out of the hospitals that were a long time and get them back and oriented back into the community. And that was one of the factors contributing to establishing what are called core service agencies. At this time, the Department of Behavioral Health was also realizing that they could not provide the direct services effectively and efficiently because there was just so many people in the district that had mental health diagnosis that the Department of Behavioral Health decided maybe late 90s that the people or agencies that were in best position to help people with mental illness would be your nonprofits that are already community-based. They know the neighborhoods, they know the community. And so DBH decided to make a shift from providing direct services to where they would be more of an oversight governing body of core service agencies, which are nonprofit agencies providing the mental health rehabilitation services. So late 90s, they shifted away from direct service to now more of a governing oversight body. And then they established contracts with nonprofit agencies through what is called a human care agreement. And these contracts were the nonprofit agencies would now provide community-based supports. We're first a mental health rehabilitation agency before we are a social service agency, even though we do social service-like things in our core service agency. But the primary goal is mental health rehabilitation in the form of psychiatric care and medication management so that people stay in the community, they stay healthy in the community, and there's less of a need to return back to a hospital like St. Elizabeth's or another hospital in DC like Psychiatric Institute of Washington. So that's the whole goal, is to keep people in the community and build a relatively normal lifestyle while managing their mental health issues. Some core service agencies also provide some unique services in addition to the psychiatric care and the community-based support.
Hello, I'm Dennis Hobb. I'm the director here, as you well know. I want to talk with you a little bit today about how financing works here at the agency. In the past, most of our funding came from the Department of Behavioral Health. However, that's shifted over the last few years. So still, a lot of our money comes through Medicaid, but various forms. As time goes on, those changes are more pronounced. So if someone has straight DC Medicaid, we bill them fee-for-service, which means we get paid in 15-minute increments usually for the services that we bill. All these services have established rates, and if someone is Medicaid eligible, when we create a bill, we send it to the Department of Behavioral Health. They do all the billing for us, and then 30% of what we receive comes from a local tax dollar match. The rest is from the federal government. We have very few people who have no insurance at all. Those people are covered by local dollars, and all those rates are the same. This all falls under the MHRS program we have, which is through the Department of Behavioral Health. However, increasingly, we have contracts with the managed care companies to do outreach, to do hospital follow-up, and those are established with different kinds of rates totally from the Department of Behavioral Health. So if our PDC team, which is the Patient Discharge Coordinator team, sees someone, it's billed at a whole different rate that's established based on what we negotiated with AmeriHealth or Trusted Health Plans, and hopefully soon with AmeriGroup. And like I said, those rates are very different than what we've done with the department. There's also a service called Freestanding Mental Health Clinic, which is only seeing the doctor or a therapist, and someone can have Medicaid and receive those services also. That's right now outside the Department of Behavioral Health, but that may change over time. They may adopt that, but still it would be a different rate. All of these things are governed by different kinds of options under Medicaid within our state Medicaid plan. And anytime a new service is added, or if they want to change the way these services are delivered, there has to be what's called a SPA, a state plan amendment to the Medicaid program. And that all gets approved through the Department of Healthcare and Finance, but the services are delivered through the Department of Behavioral Health. I know that seems really confusing, and it is. However, the big thing to know is that almost no one is uninsured for the services that we receive, or that we provide, and so therefore, their services are usually covered by some form of Medicaid. But like I said, those contracts we have with AmeriHealth and Trusted Health Plans is contract money. It's for them, it's Medicaid money. For us, we're working on their behalf, so it's contracted. We also have a program at Counseling at DuPont where we have people who can do private pay, or they can be covered by Care First or Magellan. And we collect about $110 an hour for the services we provide there on average, because they're all paid at different rates. I'm here today to talk about managed care organizations. At the McLennan Center, we work with 3 MCOs, Managed Medicaid programs. AmeriHealth Caritas DC, Trusted Health Plans with behavioral health carved out to Beacon Health Options, and AmeriGroup. These MCOs altogether account for $1.1 billion of spending by the District of Columbia. We were one of the first states here to opt into Medicaid for low-income residents, so that's kind of a good thing for us. The things about the MCO is that they only pay for professional services. When I say professional services, I mean those delivered by a psychiatrist, any doctor really, a licensed therapist, a nurse practitioner, a licensed social worker. Those are the only things that the MCO will pay for. So when someone has, let's say they have AmeriHealth, but they need community support, the services that used to be just for fee-for-service people, those things have been carved out of the Medicaid MCO contracts, so they're still paid for by DBH. So we have tons of people who have AmeriHealth. So they're getting their doctor services, any therapy services, and right now their day program services covered by AmeriHealth, but community support is carved out to DBH. The MCOs in the district serve 200,000 people, and about 40,000 additional people are on fee-for-service Medicaid. So you add this up, that means about 250,000 people in the district are covered by Medicaid. That's 40% of our population. But the vast majority of those are covered by the MCOs. There are some pros and cons for having the MCOs. One is when you are working with the MCOs, you can negotiate rates. You can't really do that with DBH. They set the rates, but you can do this with the MCOs. Their denial rates are really low. In fact, I read the other day that the claims denial rates for AmeriHealth is like 8%. I believe for trusted health plans it was 10. So that's pretty good. Also, the MCOs don't have to obey the same rules as DBH. They have to meet certain metrics in their provider agreements with the district. But beyond that, they can do pretty much whatever they want to. There's some cons with the MCOs too. One is that even though you can negotiate rates, their rates for professional services are lower than DBH's rates. Often the same as Medicare, and Medicare pays pretty low. But then again, they only pay us 80% of what we bill also for Medicare. The MCOs will pay 100%. The other con is that if the MCO is part of a national group, it's harder to contract with them. Also, the MCOs can have really onerous rules. That didn't really apply to us too much until we started doing the delegated care management for AmeriHealth. And what delegation means is that we are just like, when we do care management, we're just like an AmeriHealth employee, but they've delegated to us, which means we have to meet all of the NCQA standards they do, we have to follow all their policies, and so that can be really onerous. The MCOs are a way for the district to provide healthcare services to a defined group of people, usually based on income, not disability, though sometimes they are also disabled, and to control their costs, all at the same time meeting their contract obligations. And if they do, they get that 2% withhold that happens for them at the beginning of their contract year. We do a lot of work with AmeriHealth, some with Trusted, and it's all the innovative things that we're doing that help them to meet those metrics so they can get those $10 million. So that's pretty much what I have to say about MCOs.
My name is Michael Burt. I'm the Quality Improvement Director at McClendon Center. Quality improvement is really a way that we look at the quality of services that we're actually providing. When we say quality improvement is a program that has specific initiatives that we focus on quarterly and yearly. So we know that our staff provide a lot of services in the community where we can't actually see what they're doing. So one of the other important things that we do is called visit verifications. So our staff are required to put their schedules in the electronic medical record in advance so we know where they are. And it's up to our supervisors to call the case manager while they're out with clients to speak with them, to say, hey, how are you? How are things going? To actually verify that those visits occurred. So we do those visits concurrently and retrospectively. I think at McClendon Center, quality and compassionate services is really that we really care about what we're doing. And the way that we can kind of show that we care what we're doing is we monitor specific quality indicators. And in these indicators, we track things from when the client is first seen by their assigned case manager after they come on board. And the reason we monitor that is we think that timely access to services is really important. If we don't get the client when they first come in the door, we stand the chance of losing them. The client voice here at McClendon Center is really important. The clients can get their say with how we do things here in two ways. We have an open door policy when it comes to our management staff, from the supervisor level to the executive level. Clients can come in and they can request to speak with their supervisor, their CSS supervisor, or the executive director, or the quality improvement director, or the compliance officer, any of those people, to kind of get their issues resolved. So their voice is heard in that capacity. It's also heard through our Consumer Advisory Board, which is a group of about 12 to 15 consumers that get together with me to kind of talk about how we're doing as an agency. And I can give you an example. In one of those meetings, there was a client who indicated that it took their case manager a long time to call them back. So we took that information back to the management team, and what we did was We made all the staff change their voicemails to say that they would return phone calls within 2 hours instead of 24 hours to ensure that we really get back to the client in a timely manner. Also, the supervisors actually do test calls and they track to see how long it takes for staff to call clients back. So that's an example of where the voice of the consumer really matters. But overall, I think McClendon Center is really focused on how the consumer feels, what their experience is.
Hi, I'm Steve Luderin. I'm the Clinical Director of McClendon Center. Today I'm going to talk to you about how our intake process works, the services that our case managers called Community Support Specialists provide, as well as all the other services at McClendon Center. A client that is referred to us through the Department of Behavioral Health. That's our agency that we partner with, and they oversee the district services for mental health services. When a client's referred to us, they're referred to us to a phone called Access Helpline, in which DBH, Department of Behavioral Health, connects the client to us. Once they're connected to us, we assign an intake worker who will complete a comprehensive intake on every single client that comes into the agency. That's the first step to getting access to our services. In an intake, we go over their history, their background, their mental health issues. Every client that comes to McClendon Center, the criteria to get in is that they have to be over the age of 18, they have to have a diagnosis of a mental illness, and they must have Medicaid insurance. After the intake is completed, a team is assigned to a client, and a client is also assigned a case manager called a community support specialist. The case manager is responsible for providing and overseeing, working with the client in a partnership way to ensure that a client gets all the services that McClendon Center provides, or if we don't provide a particular service, we refer out to an agency to provide that services. So a community support specialist plays a really critical role in our agency. They are the ones that are on the front lines. They are the ones that go out in the community and meet with our clients. Every 6 months, we do an assessment on a client to see how they're doing, and then we write a treatment plan for that client. Treatment planning is really, really important because that is the game plan for a client's life. And that's also how we bill and get income into the McClendon Center agency. The services that we provide at McClendon Center consist of 4 core services. One service I mentioned earlier is the case management services provided by a community support specialist. The second service that we provide is psychiatric care and medication management. We have a team of psychiatrists and resident interns from George Washington University Hospital that provide psychiatric care to our clients. Every client has to see a psychiatrist at least once a month to check on their medications and to see how they're doing. The third core service that we provide is therapy services. Any client in our agency that wants to get into therapy, we do refer them to one of our therapists. And the fourth service that we provide in our core service in our agency is called the day program services. For those adults, those clients that need more care during the day, that need more support, and these may be clients that aren't doing much during the day, our day program provides social skills building, relationship skills building, and just a general atmosphere for our clients to come in and connect with other people that might be struggling with really similar issues. So those are the 4 core services that our agency provides at McClendon Center.
My name is Sheree Cyrus. I'm the clinical manager for McClendon Center Day Services Program. While the CSA provides medication management, case management, and psychotherapy services, Day Program provides we get people to interact, social skills, talk to each other, be around in a group setting, and learn how to deal with the group setting, taking that and putting it into use in the community. Offer 5 tracks every day, varying from health and wellness with our nurse, recovery programs for co-occurring disorders, expressive arts, which is the best, art therapy, movement, music, and other talking and activity-based groups. They're creatively named so that they empower our clients to look beyond just topics of mental illness, anger, and other things. If a client doesn't show up to our program in a day or two, we give them a call. We give them a call, leave a message, we call their case manager, and the reason we do that isn't to track them down or to keep tabs on them, but it's because we are truly concerned, because we know that our program helps them, and we want to make sure, are they okay? Is something going on? Are they isolating? Or is something else happening and they're just sick? We need to know that, but it gives them a sense of accountability, so that they themselves will call in and let us know what's going on with them, so that then they know that we care and they know that there is someone who is looking for them and looking out and depending on seeing their face. It allows people to feel that sense of community. And just like any community, when you have a piece missing, it's noticed, and that's what our clients know. In terms of what someone gets out of the day program, it is exactly the things that we've spoken about before. They get a sense of community. They get a routine. They get friends. They get the sense that someone cares, and they find out that they can believe in themselves to do more than they thought they could. So someone who used to have a job may feel like when they come here, their best days were behind them. And they learn that actually their best days are every single day that they have, because they have something more than what they did before this program. Learning how to identify how they feel, identify what they've gone through, and identify what they worked for them in the past, and build on it to take out into the community.
So I'm here to talk about Counseling at DuPont, a service program that we started about 3 years ago. Basically, Counseling at DuPont provides outpatient psychotherapy for people that are classified as the worried well. These are meaning these are people that do not have a mental health diagnosis or a mental health illness. All of our licensed therapists are professionals in the field. We have licensed professional counselors and licensed independent social workers that provide the therapy. Most of our clients that come for weekly therapy, which lasts about 1 hour, or to be exact for billing purposes, 53 minutes. The typical client that comes to us are coming for either relationship issues, stress and anxiety of dealing with workplace stresses, having a hard time transitioning to Washington, D.C. We have a lot of people that come from other states that found jobs here, and the transition from another state to Washington, D.C. causes a lot of stress and anxiety. And we also find people that come to us that are dealing with maybe childhood-related issues, dysfunctional families that they grew up, relationship problems with parents, with other siblings. The therapy that we provide is long-term therapy. Most of our clients that come to Counseling at DuPont stay with us for, on average, 6 to 8 months before they feel that they've reached their goals. Some of our clients stay a little bit longer depending on the need. And then when a client feels that they've reached their goals and completed their satisfactory what they've come in for, we do then terminate with them.
So in the past, we developed our services and structured those around meeting requirements for the Department of Behavioral Health. As I look to the future, more and more of our growth has been with the MCOs, the Managed Medicaid Care Organizations. And so what we're trying to do is to grow more with them. So our services are going to wind up looking different. What you'll probably see before long is that some of the case management community support services paid for through DBH will likely get paid by the MCOs. But that means they're going to want different outcomes. They're going to want people to not return to hospitals, to stay out of emergency rooms, because they're high cost. So they would see our services as preventing people going in. So I see those services as expanding. What we've also done through AmeriHealth is our post-emergency engagement services, also known as PEAS. We would rename it if we could, but it's called that by AmeriHealth. And when we do that, we're finding people who have been in emergency rooms, and then our outreach workers engage them in some kind of other care so they get ongoing care that keeps them out of emergency rooms or going back to them. The whole goal of the MCOs, their goal is to make money, of course, but they also want to keep people healthy so that they keep people from using high-cost services. And there's a certain kind of withhold that the city does in their contracts, and if they meet their outcome measures, they get this money back. So that's why they invest in people like us, so that we can help them meet those measures by doing some innovative and new things. And I think that's where the growth will be with our programs in the next 5 years. As healthcare changes, there's going to be a real focus on keeping people well, keeping people healthy, preventing anything from happening. And that means doing a lot more primary care in addition to the behavioral health care that we're doing. So we've kind of crossed a bridge. We're standing in the middle of it, and we're doing both kinds of things now, and that will continue to increase. Another thing that we're doing now is we've signed a contract with Medical Home Development Group that will place a primary care physician at the CSA on site at no cost to us. We just have to provide the office space. And what we can do then is, as we're finding people who are using too many medical services, we can get them to see a doctor on site with us, and we can communicate with each other through our medical records about what we're doing. So as care coordination grows, you will see less and less focus on fee-for-service and more focus on prevention and meeting outcomes.